Hello and welcome to another episode of the Ultrasound MinnieCast, brought to you by AntMinnie.com. I'm your host, Amerigo Allegretto, and today we're going to discuss the advantages and challenges of diagnosing endometriosis with transvaginal ultrasound, or TVUS for short. My guest for this episode is Dr. Scott Young from the Mayo Clinic in Phoenix, Arizona. He is a member of the Society of Radiologists in Ultrasound, and he co-authored an SRU consensus statement published in 2024 in the RSNA Journal Radiology. The statement outlines recommendations for routine pelvic ultrasound exams for imaging endometriosis. We talk about recent advances in ultrasound being used in this area and the need for standardization in imaging exams and training. And Dr. Young sets the record and this host straight on why laparoscopy alone should no longer be considered the diagnostic gold standard. We hope you take something informative from this episode into your imaging practice. Enjoy the show. All right. So, what has your experience been with imaging endometriosis through TVUS?
Yeah, so this kind of came up as a topic almost, 15 years ago with our gynecologic surgeons at Mayo Clinic in Arizona. And they were searching at the time for a way to accurately predict where endometriosis was occurring on their surgeries. And they had become aware of, since the really early to mid 2000s, that in Brazil, surgeons were asking radiologists to look for endometriosis and sort of map it really with ultrasound. And so they encouraged me to take that on, and I wasn't really sure where that would go. I mean, honestly, they came and gave a presentation, and I just looked at my college and I'm like, I thought, this is absolutely crazy. No one's ever done this before. Can you really see endometriosis other than endometrioma on an ultrasound? It really was kind of mind-boggling. But I went down there just for a week, and I hung out with a couple of radiologists that were doing this. And, unfortunately, they didn't have very many positive cases that week. They showed me postoperative cases, they showed me normal cases, but
Right.
there weren't very many positive cases. And then I came back to the U.S. and the surgeon said, "Okay, now do it." And so you just got kind of thrown in to do this and just try and figure it out a little bit on your own, because there wasn't a ton of literature around the topic at the time. And so it was kind of interesting. Like the first few cases were kind of head scratching and not quite sure what we were looking at. And actually, we did publish on that. It took about 75 cases before sort of the time of acquisition sort of plateaued and went down to a reasonable number. So it does take a little bit of experience if you're talking about mapping endometriosis. So this is kind of different than what we're talking about with the SRU consensus statement. That's more about earlier detection of endometriosis. That's a bit different. You do need to have an experience in terms of looking at the cases, but you don't really, since you're not scanning yourself and you're looking at for sort of indirect features for the most part, you're not really tasked with actually identifying small implants to tell the surgeon exactly where they are. So it's a different idea between those two sort of rubrics.
And that user dependence, that's an inherent challenge with everything ultrasound. But
Sure.
that kind of segues to my next question here. And that's what challenges have you come across when trying to cope with an accurate diagnosis with TVUS?
Yeah. So I think one of the things is that you have to realize with transvaginal ultrasound is, especially related to endometriosis, is there are a couple of different approaches. One is to look for indirect features, so that those are the things that endometriosis causes in terms of fibrosis, and then the direct features. Finding those direct features does take some time, but the indirect features are actually pretty easy to figure out. So that's one challenge if you're tasked with actually mapping endometriosis. Those are a little bit harder to figure out at first, but um, what I think has come out in the literature and what we know now that makes it a little bit easier is that we realize that there are very, very typical patterns of involvement. So the cases often look alike. So once you get some experience at looking at these cases, you can start predicting based on, oh, I see some stranding behind the uterus. Oh, well, probably the uh, bowel is involved in the mid to upper rectum. So then oh, I see that the uterus is not sliding and the ovary seems to be low. Oh, that is highly predictive of having endometriosis, again, on the bowel, probably on the uterosacral ligament, probably on the same side that the ovary doesn't slide. So, these combinations of appearances make it easier once you realize what the pattern of disease is. This goes for MRI as well. Um, you know, uh, they are not easy to interpret either, but if the person interpreting them understands the pattern of disease um, for endometriosis, then it becomes much, much easier because then your eye goes to where the abnormality is, even if the abnormality is just tissue distortion, which is the challenge in endometriosis. Is so much of what we see is not a nodule. It's not a clean organ with a nodule sitting in it. That's what, as radiologists, we're used to looking for. This is tissue distortion around normal structures and normal structures that are in slightly abnormal positions with there are signal abnormalities on the MRI. There are lesions there on the ultrasound, but they're they're more difficult to exactly describe. And so once you realize that these patterns repeat themselves, it becomes a lot easier to interpret these sorts of images.
And it sounds like when it came to training, yours was trial by fire. But have you heard anything from colleagues about challenges in training or education in this area?
Yeah, I mean, I think there's a decent amount of literature, and I certainly get feedback from colleagues around the country and around the world about where they find the challenges. Um, I think, the easier things for, again, if we're talking about mapping of endometriosis, one of the easy things to learn is how to find the ureters. Now, the ureters aren't that involved, but it sort of makes you feel good to see them every time. And I found that with our sonographers, once you sort of point out how you find the ureter, it's actually pretty easy, and it gives them a little bit of an encouragement to say, oh, I can find this structure that I don't normally look for on routine exams. So now I feel more confident in trying to assess some of the other characteristics. So, and that's been shown also in the literature that some things are easier to learn than others. Finding the normal uterosacral ligament can be challenging. I mean, if it's not thickened, it's extremely thin. It's just an echogenic line. Confidently saying where that is, even for an expert, when it's totally normal, is a little challenging at times, and depending on the position of the uterus and so forth. So, those things are always going to be a challenge. I think. Again, with the SRU consensus statement, we tried to get around some of that because we're not tasking sonographers with finding and measuring the normal uterosacral ligament. That's just not part of what we're asking. Again, I feel like we try to address that in the consensus statement.
And let's switch gears to that consensus statement that you and colleagues wrote up a couple of years ago. Um, when did discussions first come about that a consensus statement like this is needed as a reference guide for sonographers?
Yeah, so we started a couple of years ahead of probably 2.5 years ahead of it, discussing this, and I really kind of had been a sort of back burner discussion a little bit for a few years. I'd given a few presentations at SRU and other places on sort of how we looked for endometriosis, both from a mapping standpoint and then also for just routine patients. So we'd been doing routine patients, at least doing the sliding sign and sort of getting an idea of what their mid-rectum looked like, starting in around 2017, 2018 at Mayo Clinic. And then it was roughly during COVID around 2020 that we were starting to see other places so UCSF asked me to talk about it. And I think the light bulb after I told them sort of how we did it, and they started looking at UCSF for endometriosis on routine imaging. That's where the light bulb sort of went off. It's like, hey, wow, uh, this is doable. Like we can do this. And then we started having some more internal discussions, and then it kind of spilled actually from Society of Abdominal Radiology over to SRU because it really is an ultrasound thing. And so a lot of the people that are on the disease focus panel for endometriosis from Society of Abdominal Radiology also are fellows in our SRU. And so we kind of switched it over to SRU because SRU wanted to take it on as a consensus statement.
And what feedback have you and others received since the statement came out?
Yeah, so it's been interesting. Like I think some of the initial feedback, there was a little bit of pushback from gynecology saying, well, we're not really sure about some of these indirect signs, and shouldn't you treat all the patients the same, and shouldn't every patient come in for a dedicated ultrasound for endometriosis? And our answer to that was we considered all those things, right? So, but what we wanted to do is create a way of finding the disease earlier, and in order to do that, we have to put the absolute detection of individual lesions sort of we put that off to a secondary imaging study, and we want every patient that may have symptoms of endometriosis who comes in for a routine ultrasound to have the opportunity for the radiologist to at least consider whether endometriosis is present in the images that were routinely obtained. So we considered that these images needed to be taken within 5 minutes. And honestly, we've shown that for example, the sliding sign, that only takes about 30 seconds to obtain an image of the sliding sign. So that's one thing. Then we said we want video clips that go through the posterior compartment. Well, many labs take video clips of the endometrium already. So if you just make sure that you're including the posterior compartment when you take those video clips of the endometrium, that adds no time to the exam. So we're really not, for one thing, not tasking sonographers with doing a lot of extra imaging, but we are tasking the person who interprets the images to look at those areas in addition to focusing just on the uterus and endometrium, to focus their attention also on the posterior compartment. That's really all we're asking. So I think those are things that we sort of tried to anticipate as criticisms, but nevertheless, a lot of people who have expertise in this area are going to say, well, why doesn't every patient come in and get the expert exam? And it's just, there are millions of pelvic ultrasounds done in the United States annually. There's just not going to be enough experts. I think if you give sonographers the opportunity to think about looking for the disease, then gradually this will come into sort of a general knowledge base, and that's the way to go about this, rather than saying don't look unless you're an expert.
And do you foresee any updates to that statement in the near future?
Yeah, we haven't looked at that quite yet, but initial data are coming back, so that we had the first prospective study come out of China just 2 weeks ago. It was published in the European Journal of Radiology of 288 patients, looking prospectively at how the both the direct and indirect features performed. And so what they found was that these indirect features are, again, very, very important. So those things that we can just sort of routinely see on a pelvic ultrasound, things like fixed uterine retroflexion, malposition of the ovaries, uh, abnormal sliding, those kinds of things, those really do accurately predict the presence of endometriosis, at least the moderate to advanced stages. And so they've shown that those somewhat criticized indirect findings are actually very useful. So
Now,
we might find out that they're even better than we thought. And so one of the things is that we're recommending that patients go on to advanced imaging only with a direct feature or at least a couple of indirect features. But maybe some of these indirect features are enough to say all those patients need to go to advanced imaging.
laparoscopy, it's still the gold standard for
Sort of.
diagnosing.
It
Sort of.
really isn't. Yeah, it isn't. Okay. So it's not the gold standard anymore.
Mhm,
The gold standard from multiple gyne societies is laparoscopy directed by expert imaging.
mhm.
That's the gold standard now for endometriosis. It's not laparoscopy. It is laparoscopy directed by expert preoperative imaging. So in the US, that's more often going to be MRI. Worldwide, it's more often going to be expert transvaginal ultrasound. But laparoscopy alone is not an adequate gold standard. Why is that? Well, we know that the sensitivity of video laparoscopy alone is under 10% for rectosigmoid endometriosis, right?
Mhm.
Whereas the sensitivity of bowel prepped transvaginal ultrasound is over 95%. So the imaging is better at detecting very advanced stages of endometriosis that can be completely under the peritoneal surface, compared to laparoscopy. So, uh, there are going to be a lot of gynecologists out there still saying that the gold standard is laparoscopy, but that's not entirely accurate.
And that brings me to my next point here, and that's what does TVUS have going for it that it should absolutely be added in your eyes to, whether you want to diagnose with or without laparoscopy?
Right. So the image detail, because the most common locations for endometriosis are right behind the cervix, so the retrocervical region, the area where the uterosacral ligaments kind of come together in the midline just behind the cervix, and then the immediate rectum right there. When you put the transducer in the posterior vaginal fornix, you're right on top of that area. So if you're scanning at 9 megahertz, which is your higher frequency with a transvaginal ultrasound, the image detail there is not paralleled by anything, even MRI. So for most disease, you're going to get the most detail in terms of the size, location, and extent of disease with ultrasound. Um, and why is that important? Because it actually matters to the surgeon exactly how long that lesion is, exactly how deep it penetrates the bowel wall. It changes how they do the surgery, and it also changes the risk of the surgery. And so it changes the preoperative planning, and patient consent, obviously.
Now, this has been on my mind for other areas in ultrasound, but the current state of radiology in ultrasound, do you personally find that more non-physician practitioners are performing transvaginal ultrasound as opposed to radiologists?
So in the US and Canada, especially, almost all ultrasound is performed by non-physicians, right? So very few physicians in radiology, at least, are performing their own ultrasound. We see ultrasound being performed by physicians outside of radiology, but within radiology, they're almost never performed by radiologists unless you're guiding a procedure. So I think in residency training, we still need to continue to emphasize scanning skills for radiologists, because we are the final arbiters of what's normal and what's abnormal, and you need to have some skills in scanning. And those can be acquired during the training period, but we need to make sure that's happening.
Now, ultimately, in Dr. Young's eyes, what is needed to further advance transvaginal ultrasound for this application for diagnosing endometriosis?
Sure. So I think one thing is to have a better consensus around how exactly to perform the examination for mapping. Currently, the international consensus doesn't specifically say that you need to do bowel preparation, and a lot of experts around the world will do it without bowel preparation. But if you ask the real experts, they think that's bonkers, right? It's just like, how would you see any secondary um, bowel lesions without bowel prep, right? So you can see that primary lesion that's often right behind the cervix without bowel prep, but you're going to miss all of the other lesions. And we know that a high percentage of patients will have multiple bowel lesions. So having that bowel prep as sort of an international standard, I think, is important. And then I think just sort of accepting that when we don't have bowel preparation on a routine patient, that we should still be commenting on whether or not we see features of endometriosis. So those are the kind of two. They're very different sides of a coin, but we need to consider both of those things.
And do you foresee AI helping in any of this?
I think the first area where AI could help, I think one area is adenomyosis detection. So this is an associated disease, but it can be a little bit difficult. So I think that's one thing we're working on. And then I think for AI detection, I think these indirect features are going to be super important there. So I do think that we will see AI helping radiologists recognize when the uterus is retroflexed and not mobile. It may be helpful in recording some of these sliding sign maneuvers, but ultrasound is tough when it comes to AI, because there aren't those clean acquisition planes. It's harder to train for AI perhaps than CTRMR or other standard cross-sectional imaging. So we'll see. It's not going to replace the eyes of the radiologist anytime soon.
All right. Well, any other thoughts before I let you go? This has been a very enlightening conversation.
No, thank you so much for, again, calling attention to this area of imaging. I think whether we're talking about MRI or ultrasound, endometriosis is a topic that really deserves way more attention from radiologists than it currently gets. So thanks so much.
That's all for today's show. Be sure to check out the ultrasound section on antmini.com for the latest news in research, practice, and policy. And if you like this podcast series, you might also enjoy other series on the Ant Mini Podcast Network, including Keeping Up with the Radiologists, The Invisible Force, hosted by Tobias Gilk, and the Women's Imaging MinnieCast, hosted by yours truly. Stay tuned for the next episode of the Ultrasound MinnieCast, and we thank you for your continued support. Until next time.